Welcome to Effective Communication Strategies, Diagnosis, Shared Decision-Making, and Follow-Up. In previous sessions of the VTE Heartbeat series, we provided an overview of VTE, discussed specific assessments and considerations for patients with VTE, including anticoagulant selection for a typical patient with VTE and patients with more complex conditions, such as during cancer treatment. And we've reviewed the journey of VTE diagnosis and subsequent treatment from the patient perspective. Today, we're going to focus on communication between patients with VTE and healthcare providers. We'll start with communicating a diagnosis of VTE, moving into shared decision-making during treatment selection, including side effects and potential complications, and communication during and in between VTE follow-up visits with healthcare providers. We will also discuss the importance of communication to maintain safety and maximize care quality when patients with VTE are navigating care transitions and undergoing surgical procedures. As we get started, I want to mention that this series is supported by an educational grant from the Bristol Myers Squibb and Pfizer Alliance. Recommendations and opinions presented may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA. The AHA does not endorse any product or device. Hi, I'm Dr. Erica Shore, Associate Professor and Chair of the Adult and Gerontological Health Cooperative in the School of Nursing at the University of Minnesota. And joining me is a distinguished multidisciplinary panel.
Hi, I'm Tara Leck. I'm a pharmacist and Director of Anticoagulation Services at Beth Israel Lahey Health.
Arthur Allen, Clinical Pharmacy Specialist and Anticoagulation Program Manager at the VA Hospital in Salt Lake City, Utah.
Hi, I'm Jeffrey Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan.
Start with you, Jeff. Share with us how a patient might be diagnosed with a VTE event. Where does this diagnosis tend to occur?
Patients with VTE, meaning either a deep vein thrombosis in their leg or a pulmonary embolism in their lung, can be diagnosed in many different settings. Sometimes they present with acute symptoms, and so they're in the emergency department when they get that diagnosis. Other times they present with symptoms and they might show up to their primary care doctor or a different outpatient clinician. And then sometimes they're getting imaging for some other reason. Often patients with cancer are getting scanning CTs to stage or look for progression of disease, and they may identify a blood clot. So it can really happen in a lot of different places.
So then who's responsible for making a formal diagnosis and then subsequently discussing the role of anticoagulant treatment with the patient?
You know, most of the time, whatever clinician ordered the imaging, meaning the DVT scan if it's for the legs or the CT scan if it's a pulmonary embolism, I think that clinician is probably responsible for communicating with the patient about the diagnosis. Now, sometimes it's a clinician who feels very comfortable. You know, they're managing that condition all the time, and so they feel very able to share the details with the patient. Other time, it might be somebody who doesn't really manage DVT or PE very often, so they may choose to include a different clinician who has more expertise or familiarity. But whoever ordered the imaging really should be the person who's communicating with the patient first and foremost.
And thinking about that communication with patients, are there any best practices that should be followed?
Well, I think it's really important to explain to a patient what it is they're seeing on their CT scan or their DVT scan in language that they can understand. So that means avoiding the medical jargon. I tend to use blood clot rather than VTE. I tend to talk about a blood clot in the veins of the legs or one that's gone up and gotten stuck in the lungs, rather than using those more technical terms. Helping them understand why it may have happened can be really helpful. And then, of course, telling them what we're going to do about it. So usually that involves talking about anticoagulation and helping them understand why we use an anticoagulant. I think those are some really important elements.
Great. So they understand the rationale for it. And once the patient knows they're eligible for oral anticoagulation therapy, there are several different options for patients to choose from. Tara, what are some best practices in communicating these options to patients?
Great question. So once the patient's been diagnosed with a blood clot, communication is everything. But you also have to keep in mind that the patient is likely feeling very overwhelmed by their new diagnosis. So the key is to strike a balance and really try to provide enough information to keep the patient informed and allow them to engage in decision making without overwhelming them with complex pharmacology or terminology that they're likely to not understand. Let them know that while multiple treatment options might be available, not all are going to be appropriate for every patient. And that's why you're going to focus or really tailor your discussion on, one or two best fit options rather than giving them a laundry list of every available medication.
Great points. So, on that note, how much guidance can a clinician offer in pointing patients towards or away from certain anticoagulant medications?
Well, I think it's important to understand that as the clinician, you're going to have a better understanding of which options are most appropriate for that patient. So tailor your discussion to a level that is appropriate for their understanding. Like Dr. Barnes had mentioned, it's good to speak in terms that they know, like for your blood clot, we're going to give you a medication that's going to prevent you from having another blood clot, and then really start to better understand their personal goals and preferences, their lifestyle, and which agent might be better for them. Are they someone that needs that hand-holding and following, that they're going to need monitoring of a medication? Or in the case of most of your patients, they're going to be looking for a DOAC, and then we're going to start to look at their lifestyle and preferences in terms of, once a day or twice a day medications, interactions, other bleeding risks that might make one more desirable over another. The worst thing that we can really do is to kind of lay out all of the choices and present it to the patient like it's a menu for them to choose from. As clinicians, it's really our responsibility to use our specialized training to help them navigate that menu.
Great, thanks. And after a treatment's been selected, most patients then want to know, what are the side effects of this medication or medications that I'm going to be taking? Arthur, what would you say are some of the most important side effects that should be discussed with a patient?
Well, in the warfarin days, I would often remind people that warfarin was associated with alopecia, and then I would say I'd been working with it for 20 years. But the actual concern that we have for anticoagulants really is quite simple. It's bleeding. Now, it's important that we help patients to understand that anticoagulants don't make you bleed. If you were to have a reason to bleed, then they increase the likelihood that you lose more blood, that you'll have a worse outcome, but they don't create a bleeding source. And that can actually be contrasted against some of the interacting drugs that we worry about, things like anti-inflammatories and like aspirin, which actually can create a bleeding source. And so that's another reason that it's so important to highlight those aspects. But really, bleeding is a concern. I have a lot of patients that ask about long-term side effects of these medication, and the answer really is the longer you take a medication, the more likely you are to at some point develop a source of bleeding and have that source worsened by being on an anticoagulant.
Yeah, so there are appropriate risks that the patient needs to know about. And as Jeff and Tara both pointed out, we can quickly overwhelm patients with massive amounts of information, or in this case, unnecessarily alarm patients. So how do you strike that balance in risk versus overwhelm?
Well, I mean, again, I think that it goes back to helping them understand that these medications don't make you bleed, and that the risk of bleeding is actually, as long as we do what we can to modify the risk of bleeding is not terribly excessive, and we can also give them some confidence in the things that we do to oversee them to keep them as safe as possible. In the place of warfarin, maintaining therapeutic INRs, making sure that they're having their INRs checked, making sure that they're well educated about the kinds of things that can cause, warfarin to go wonky. In the case of DOACs, the importance of taking the medication as prescribed. The fact that we may be from time to time ordering some blood tests to ensure that we're not seeing changes in, for example, renal function that might affect the required dose and those kind of things. So I think if we can give them confidence that they are in good hands, and we can let them know that anticoagulants, when well managed, are relatively safe medications. They're not, we don't leave them laying around in candy dishes for people. They're not something that you just want to take willy-nilly, but when they're indicated and when they're well managed, then the benefits significantly outweigh the risks.
Great. Jeff, you described how this diagnosis can take place in a variety of settings, right? And thinking about urgency in an emergency room. And so patients often, they have questions when they go to a clinician's office visit, right? So they're out of that initial diagnosis phase. And so what types of questions should patients think about asking and preparing for these visits?
Well, one question I see people asking all the time is, why did this occur? And I think that's a really natural question. And frankly, it's a good question. Unfortunately, it's a question we often can't answer. And so I often encourage them to think about, what are the things we're going to do to try and prevent this from happening in the future? So as a clinician, I often guide that question in a different direction. But I do think there are other questions that patients should be asking, such as, how long should I stay on this medication? Is this the right dose for me? Am I taking it correctly? You know, the time of day, with food or without food, things like that. And then, of course, we always want them to come forward with any concerns that they may have. So I encourage my patients to keep a list, right? Write down the questions so that you're not trying to remember them while you have that, precious few minutes in the office with the doctor, the nurse, the pharmacist, whoever it is that you're meeting. So have those prepared for yourself.
So inevitably, patients often have questions that will come up outside of that office visit, right? So say they were doing the note taking, as Jeff suggested, and they just had a visit. Tara, who should a patient or a family member reach out to in between visits?
That's a great question, because inevitably things are going to come up as situations happen, like when a patient misses a dose, they want to start a new medication, or they start to experience a new symptom or side effect of their medication. So in most cases, patients, family members, they're going to have access to some designated point of contact in their healthcare system, whether that's their anticoagulation clinic, a clinical pharmacist, a nurse navigator, or the primary care office. It's important to let the patient know who that person is for them and how they're supposed to access that resource. Never assume that they're just going to know who to call, or that they're going to be able to figure it out on their own.
And once they place that call or send that message, is there important information they need to share about their individual kind of experience or history that's important when they are seeking guidance about VTE side effects or anticoagulation therapy?
Yeah, absolutely. We always want to try to set the patient up for success. So first off, let them know if a phone call or secure messaging is preferred. And if it's the latter, that secured messaging through a patient portal, make sure that they have access set up before they leave your office. And then whenever they're going to call you or have to leave a message in the portal, teach them how to be helpful. So ensure them that they need to be clear why they're reaching out. They should share specific details, particularly their name and date of birth, their indication for anticoagulation, and the drug and the dose of the medication that they're taking. And then give a clear, concise, explanation of the problem. Are you, experiencing any bleeding? Are you going for a procedure and you want information on what to do with your anticoagulation? Whatever it is, we want to instruct them to be as clear and concise as possible so that we can respond as quickly as possible to keep them safe.
That's helpful. Thanks, Tara. Transitions of care are particularly high risk for patients that are using anticoagulant medications. Arthur, would you say there are any best practices for navigating these care transitions from a health system perspective?
Yeah, so care transitions can be tough, and I think that one of the problems with care transitions is even knowing who owns the anticoagulation therapy. In a practice like mine, like Tara's, like the anticoagulation service that Jeff works with, you have dedicated anticoagulation services that are overseeing patients. A lot of the times, even DOACs nowadays that are being overseen. And you have that kind of team whose focus is primarily anticoagulation therapy, but that is not necessarily standard everywhere. So is the therapy owned by, is it a cardiology indication? Is it a vascular indication? Is it a neurology indication? Who has been kind of like owning that therapy? And notoriously what happens is that now in a different care setting, the provider says, well, I'm not going to touch it. Somebody else put the patient on there, when in fact, the very reason the patient is there could be impacting the risk benefit. It could be impacting the appropriateness of dose. It could be impacting concomitant drug therapies that could change the risk profile. So I think really the key is understanding who owns the therapy and ensuring that there is thoughtful consideration when the patient's clinical scenario and disposition changes, and not being afraid to ask the hard questions. I know this isn't my therapy, but know what it was prescribed for, know if something has changed, kind of at minimum. I think in an ideal world, then you have systematic handoffs, and this we now have, of course, medication reconciliation, which is done on admission, on discharge. But I think having either systematic or even warm handoffs at care transitions is probably the best way to keep patients safe, and especially if there are any questions, that definitely a way to at least be asking and answering the right questions.
Great. So thinking about some situations that might come up, for example, surgical procedure, patients would need to temporarily stop their anticoagulant for a surgical procedure. And this is inherently complex and risky. Jeff, what would you say are some strategies that patients and healthcare providers can use to ensure a safe perioperative period?
Well, you're absolutely right. The perioperative period is one of the most complicated and therefore risky periods for patients who are on any sort of antithrombotic agent. And so there's a couple things that I think people can do. First off, for patients, it's really important to know what drugs you're taking, what the name of the medication is, what the dose is, when they take it, as well as what procedure they're having and on what day. Because if they come to me and they ask for guidance, I need that information to be able to provide them with the best recommendation. The second thing is knowing who's doing the different procedures and who are the different team members, so that if I'm not prepared to make the decision on my own, they can help me figure out who I need to reach out to. Maybe I need to talk to their surgeon or to their neurologist or to their hematologist. And so knowing who's on their care team so that I know who I'm going to reach out to can be a really helpful strategy for them. As clinicians, I think there's a couple things we can do as well. And one of those is being very explicit with the recommendations we give. So if you look in the guidelines, they often talk about hold a medicine for 24 hours or 48 hours. But what exactly does that mean for a patient? We find it's much more helpful for patients to create a mini calendar. So if you know that your surgery is on Thursday, that means that on Monday, you're going to take your pill in the morning and in the afternoon. But on Tuesday, you're not going to take your pill. And on Wednesday, you're not going to take your pill. Thursday's your surgery. And on Friday, we're going to let the surgeon determine when you should restart it, whether it's Friday afternoon or whether it's Saturday morning, right? And drawing that out so they know exactly on what day of the week they're having a procedure, that's a very effective way of communicating with patients. At a system level, there's other things you can do as well. Maybe you want to think about building systems that identify when patients on blood thinners like anticoagulants and antiplatelets are having procedures so that you can automatically route them to somebody like a clinical pharmacist who's going to be that coordinator. Because we know so often patients don't know who they're supposed to ask these questions of. So creating a system that directs patients to the right person, creating those guidelines, those institutional guidelines that help make the evidence-based decisions and communicating it in a way that's really easy for the patient to understand and for clinicians to check and say, okay, I see that you were supposed to take your pills on Monday, but not take them on Tuesday and Wednesday. Is that what you did? So then patients can verify, yep, I followed the instructions and I'm safe to go ahead and have my procedure. Those are all really effective strategies to use.
That's great. Does anyone have any final thoughts or points that they'd like to make?
I think the one other thing that I would add to all of this is, in addition to us communicating effectively as clinicians to patients, it's really important that we be effective communicators amongst each other. And so sometimes that means reaching out to another clinician. I may call a pharmacist and ask for help, or I may talk to my colleagues in surgery or hematology. But it also means that the documentation we do needs to be really clear. Arthur, you were talking about the importance of care transitions and maybe handing off who's owning the anticoagulant management. In my notes, it's really important that if I'm going to hand that off to a primary care doctor, I explicitly state that. Patient has atrial fibrillation. They're continuing to use this anticoagulant at this dose. I'm going to turn over management of that to their primary care doctor. So that way it's really clear what's happened and there's not confusion about who's managing it.
Excellent points, Jeff. And as a nurse, I'd be remiss if I didn't mention that professional communication that is essential, right? So patients spending a lot of time with nurses at the bedside or in a clinic. And so those are great opportunities for further education and to really make sure everyone's on the same page.
Well, and I find that when I do a better job of documenting the plan, the rationale, then when a patient calls with a question, the nurse can actually answer that because they have the information there. So that reduces the burden on me as a clinician. It's a better experience for the patient. It's empowering the nurse or the pharmacist, whoever they're calling. So that communication is such an important tool for all of us to use.
It kind of goes back, Jeff, to if it's everybody's job, it's nobody's job, right? And if you don't know who the responsibility lies on, then it leaves it open to everybody assuming that the responsibility falls to somebody else.
Yes. So clear communication is key. I think that we emphasize that today, the communication between patients with VTE and their healthcare providers, really thinking about the importance of communication along the entire journey. So starting at the time of diagnosis and treatment selection with this goal of shared decision making and a focus on balancing this information that we're providing to patients in order to properly inform them, but not overwhelm patients, but so that they have enough information about potential side effects and complications. And we brought up some really great points about how patients can communicate effectively with healthcare providers, not only during those visits, but what do they do in between when something comes up? And this importance of communication to maintain safety and maximize quality of care when patients with VTE are navigating these care transitions or undergoing surgical procedures. And so that communication with patients and interprofessionally is really key. I want to thank you, all our panelists, for joining us today and the American Heart Association. This series is available through all major podcast platforms. To claim credit, visit learn.heart.org.